All right, we're going to get started. Welcome to the neurology lecture series. Today we have an epilepsy talk by Dr. Chris Beatty from Seattle Children's Hospital. And a little bit about Dr. Beatty. He did his undergraduate degree at Duke University, his medical degree at Case Western in Cleveland, and then his residency in pediatrics and a fellowship in pediatric, and then completed pediatric neurology, all at the University of Washington, and then did a fellowship in epilepsy at here at the University of Washington as well, and is now currently a senior fellow at Seattle Children's Hospital. Chris.
So today I'm going to talk about epileptic encephalopathies of infancy and childhood. It's a pretty daunting topic as there's lots and lots to talk about, and it's really hard to kind of make sense of it. We'll go through, I kind of tried to structure it at least so we can hit some high points and try and somehow tie it all together in some cohesive way and not just list all the epileptic encephalopathies. So the learning objectives for today are to be able to identify some of the common epileptic encephalopathies by age group and really start to think about them in terms of the developmental windows, thinking about kind of the ones that present in neonatal period versus infancy versus childhood, as well as to understand the basic treatment and outcomes of some of the epileptic encephalopathies that really help guide us in terms of prognosis to the families and decision making. So to start off with, what is an epileptic encephalopathy? And the most recent definition by the ILE in 2010 says that the thought is that the epileptic activity itself contributes to severe cognitive and behavioral impairments beyond what would be expected from the underlying pathology alone, and that they can worsen over time. And I think the general idea behind this is that kids who have epileptic encephalopathies, it's not just the underlying diagnosis of whatever caused the encephalopathy. It's not that the seizures themselves are causing harm. It's that the EEG is very abnormal, and the burden of all of that abnormal electrical activity is causing them to decline. And it's kind of a departure from how we normally think about epilepsy, where you hear us say, don't chase the EEG. As long as the seizures are under control, they're doing well. And in these kids, it's very different, where you actually do want to chase the EEG and try and clear up the abnormal electrical activity that's causing them to decline. So this is a list of a lot of the epileptic encephalopathies, so you can see why it can be a little daunting to try and even pick which ones I'm going through, given the fact that there's quite a few of them. And we can talk about how there's some in the neonatal period, infancy, childhood, adolescence, and there's a huge list. I will definitely not be going through all of these today, but just to get a flavor of the ones that actually have a name. And there are many that do not have names, and we just end up kind of calling them epileptic encephalopathy NOS. So there's lots of challenges about talking about epileptic encephalopathies. The first of which is that the definitions are poorly defined or they change over time. And a great example of this is Dravet syndrome, where when it was initially defined by Charlotte Dravet, it was kind of this clinical picture of what the child looked like, the different types of seizures. And then as time went on, we discovered that a lot of these children had SCN1A mutations, and then we thought that it was a sodium channelopathy. And then as we learned more about it, we realized, well, only about 70% of those kids actually have the mutation in the SCN1A channel, and that mutation in the SCN1A channel can present with other epileptic encephalopathies. And so it's also really hard to retrospectively even compare old studies to new studies because the definition is changing over time, and there's not good cohesion between the epileptologists when they do their studies in terms of what they're using as their definition. The incidence of these diseases is very low. So for the most part, it's a lot of retrospective single-center studies. Pediatric epilepsy has not been very good about doing multi-center trials. It's one of the things that we're working on as a group, and going forward, the hope is that we'll be able to do more of it. The other challenge is the diagnosis itself cannot be present until later on in the disease, meaning like with Dravet syndrome, that child presents with a seizure around 6 months to 1 year of age. You might not actually be able to give them the official diagnosis of Dravet syndrome until they're 1.5 years, 2 years of age. So if you're doing retrospective studies, it just depends on what point in time you catch them as to whether they're included in the study or not. So it's a very challenging disease process as a whole to study. And etiology is the other piece of this that makes things very difficult and is also changing over time. We kind of think of etiology as this idea that we know kids who have specific etiologies and go through and develop epileptic encephalopathies have different outcomes. but it's really hard to piece all that together. And because the numbers are so small, you can't break down the epileptic encephalopathies by etiology subtype. And there's lots of overlap between the two. And I think tuberous sclerosis is a great example where, it's structural in the sense that there's tubers that are causing epilepsy, but we also know there's a genetic component. So which category do we necessarily put it in, and do we just think of it as its own disease process? So the way that we tend to think about these is try to divide them by age group. And one of the terms that you'll hear us use is kind of age-dependent epileptic encephalopathies. And the idea behind it is that as children move through specific developmental windows, we see that their epileptic encephalopathy kind of expresses itself in different ways. And here's an example of some of the neonatal epileptic encephalopathies, some of the ones in infancy versus childhood, and the lines are not very discrete, and they kind of blur together over time with the outliers in terms of the age ranges. I'm going to today talk a little bit more about kind of Ohtahara syndrome, infantile spasms, Lennox-Gastaut, and then some lookalikes. And the reason that I pick these is because of the fact that you actually see this spectrum where kids in the neonatal period will present with Ohtahara syndrome. About 3/4 of them will go on to have infantile spasms, and about 60% of those with infantile spasms will go on to have Lennox-Gastaut, and it has nothing to do with the underlying etiology. So it could be related to a perinatal stroke, it could be related to a cortical dysplasia, it could be related to an underlying genetic diagnosis, but you see them kind of pop up with these different EEGs, different seizures at different points in time. And so it's really just the expression of that epileptic encephalopathy during different developmental windows. And so this is kind of the way that we think about it, is you kind of get this mix of these different etiologies that can at this point in time present as Ohtahara syndrome, at this point in time present as infantile spasms, and at this point in time present as LGS, and a child can actually hit all three of these, hit two of them, hit one of them, or hit none of them, all with the exact same diagnosis, and we don't necessarily understand why. There's vague theories, but it's not very well understood. So what I'm going to focus on today is kind of this spectrum of these disease processes, and then talk about a couple of lookalikes specifically in comparison to Ohtahara syndrome and to LGS. So Ohtahara syndrome is one of those diagnoses that I feel like everyone has heard of at some point in time, but we rarely ever see, given that it's always in the neonatal period, as well as the fact that it's extremely rare. The largest case series that I could find had 16 patients and was from about 12 years ago, just because it was done by some of the groups that actually are very, very interested in epileptic encephalopathies, and they produced a large volume of these papers. So it typically presents in the first month of life, and here you can see that there were a couple that went all the way out to 3 months, but it's pretty uncommon. These children typically develop tonic spasms that can last up to about 10 seconds and occur hundreds of times per day during wake and sleep. Tonic spasms is a type of seizure that's very vague. We like to say we call spasm seizures that usually have a specific EEG characteristic that lasts for about 1 to 2 seconds. And tonic seizures, we think of something that lasts for longer than that with usually a similar EEG signature. And so we tend to label something tonic spasms when it's kind of in that gray area in between. There's not really a great official definition of tonic spasms. And then a third of these patients go on to develop other seizure types, such as focal motor seizures or full-on tonic seizures that last for longer in duration. There's a very characteristic EEG with Ohtahara syndrome, and it's a suppression burst pattern on EEG. Now, we used to call this burst suppression pattern, but we've changed over and usually now say suppression burst to kind of emphasize that the suppression is actually the abnormal portion of the EEG. And you'll see these bursts of activity for about 1 to 3 seconds and then suppression for about 2 to 5 seconds. It's in variable state, so it's present all the time, whether the child's awake, whether the child's asleep, whether the child is interacted with. And I can tell you that most of these kids are very encephalopathic, so they're not really awake and interacting with you in the normal way. And it disappears by around 6 months of life, and a lot of times actually evolves into some of the other EEG patterns that we'll talk about that go along with infantile spasms or with Lennox-Gastaut. So this is a pretty classic Ohtahara EEG, and you can see the burst here, the suppression following, and kind of just a repetition of this pattern. There's a few buried epileptiform discharges in here. And people who are familiar with neonatal EEG will say, isn't this kind of what neonatal EEG looks like anyway? And really, for a term infant, this is very abnormal. You really shouldn't have this degree of suppression. You should have variability in the EEG over time, as well as the fact that this EEG won't mature at all. It'll just stay like this for about 6 months. So the causes of Ohtahara syndrome are pretty broad, but most commonly we think of it associated with structural abnormalities. Things like hemimegaencephaly, where you actually get overgrowth of one half of the brain, with a hypoxic injury or some type of cortical dysplasia or perinatal infarct. There's also genetic etiologies that have been associated with Ohtahara syndrome. STXBP1 and ARX are two of the most common ones, and these genes can present with other types of epileptic encephalopathies, but they're pretty well known to cause early infantile epileptic encephalopathies as a whole.
Do they go along with hemimegaencephaly or the
Not necessarily. No. With hemimegaencephaly, a lot of times you're thinking more of kind of the mTOR pathway or the PIK3AKT pathway, so it's actually a separate set of genes that can be.
I was thinking that.
So there you go. But they don't necessarily go along with it. So the treatment of Ohtahara syndrome is pretty tough. Phenobarbital, valproic acid, zonisamide, and pyridoxine have all shown minimal efficacy. A lot of people wouldn't even consider using valproic acid in a kid this age just because of the possibility of an underlying mitochondrial metabolic disease that could tip them over the edge, but you can get pretty desperate. Ketogenic diet is a possibility, and there's some efficacy in using it in this population, but it can be really challenging to use the ketogenic diet in kids this age because in order to get them into ketosis, you have to calorie restrict them to the point where they don't necessarily grow the way that they should. Epilepsy surgery is an option if there's actually a focus on their imaging, and we won't hesitate to do epilepsy surgery in a kid who's very young if it's really kind of a last-ditch effort and we see something that we can go after to dramatically improve outcomes. And then if they go on to have infantile spasms, in this group, ACTH seems to be more effective than other modalities. So prognosis-wise with regard to the seizures, so the black bars here in the case series are when they presented with the burst suppression pattern on their EEG. Then you can see this kind of dark gray is when they developed hypsarrhythmia to go along with infantile spasms, and then the lighter gray are when they developed the slow spike and wave that goes along with Lennox-Gastaut. And so you can see that they tend to have a lot of times this progression where they're going to go from black to dark gray to light gray as they move through those developmental windows that I was talking about. There's also a few kids who pass away associated with the significant morbidity with the disease process. So a lot of kids pass away within the first 2 years of life because they have significant neurologic impairment, and it puts them at risk for aspiration pneumonias as well as other issues with being in and out of the hospital on a regular basis. And those who do survive have severe cognitive impairment and a lot of times have quadriplegia as well. And as you can see, kind of in that same chart, a lot of these kids will go on to have infantile spasms and other epileptic encephalopathies as they get older. So the one lookalike for Ohtahara syndrome is early myoclonic encephalopathy, and this one doesn't get talked about as much as Ohtahara, I think, because it doesn't have kind of that name that goes along with it that sticks out in everyone's mind. It once again presents around birth to 3 months of age, and what's different is that these kids have myoclonus as well as focal seizures. But they also have that suppression burst pattern on their EEG, which is why a lot of times there can be some confusion between the two. So on the EEG for early myoclonic encephalopathy, you see that suppression burst pattern, but it actually varies between wakefulness and sleep. And during wakefulness, you'll see more of a hypsarrhythmia pattern, then they'll go to sleep and you'll see the burst suppression pattern. They also don't necessarily with the myoclonus, a lot of times that you don't see it corresponding with EEG changes, so it's really thought to be kind of subcortical myoclonus. And then there's no evolution in the EEG pattern. So these kids will have that pattern of hypsarrhythmia during wakefulness, burst suppression during sleep for years. So they don't kind of move through those developmental windows in the same way. Unfortunately, kind of once they get it, they're stuck with it. And this is an example of the EEG, and we'll talk about hypsarrhythmia a little bit more, but this is the hypsarrhythmia during wakefulness, and then this is the burst suppression pattern that you see during sleep. So the most common etiology for early myoclonic encephalopathy is actually non-ketotic hyperglycemia. And non-ketotic hyperglycemia is one of the metabolic abnormalities that actually comes up in our differential pretty commonly for new onset neonatal seizures. One of the things that's kind of one of the pathognomonic findings is these kids tend to have hiccups associated with their seizures at birth. So if they're hiccuping and having seizures, we always think about it. In the past, we would have to do a lumbar puncture to tap them to look at their plasma amino acids, but now we're able to do an MR spectroscopy, and you can actually see a glycine peak in a lot of these kids that's diagnostic. There's other metabolic etiologies that can go along with EME, but this is the most common one. Treatment is basically nil, so anti-epileptics pretty much do nothing for this disease process. There's almost nothing that we can do. You can try to treat the underlying non-ketotic hyperglycemia with sodium benzoate, and there's some research that maybe it helps a little bit, but for the most part, there's not a lot we can do for these kids. 50% of them die by 2 years of age, and all those that survive have severe psychomotor deterioration. And then one of the studies that specifically looks at these coming from the Asian group describes the ones who do survive are in a persistent vegetative state. So they really don't have any way of interacting with their environment. So this one's a pretty abysmal diagnosis.
What's the cause of the elevated glycine?
So they actually have a defect in glycine degradation, so it's an underlying a genetic defect, and I can't remember what the actual defect is in the pathway off the top of my head. So here's just kind of to compare and contrast the two. So with Odahara, you're going to have the suppression burst during wake and sleep, and then you have resolution over time. With EME, you're really only going to have it during sleep. You've got different types of seizures. The etiologies that are most common are structural versus metabolic, and then the outcomes are a little bit different just because Odahara ends up transitioning through the other developmental windows, whereas EME is pretty persistent. So we kind of talked a little bit now about the neonatal window and these specific entities. Now I'm going to move on to infantile spasms. And I think of these group, infantile spasms are probably one of the diseases. Yes?
Chris, before you move on,
yes.
So you mentioned the interictal EEG on both of those conditions.
Yes.
Can you mention something about the ictal EEG?
Sure. So with the ictal EEG, and sorry, the question was about talking about the ictal EEG with these disease processes. So with Odahara, with the tonic spasms, typically what you're going to see is usually a slow wave followed by fast activity with some electrodecrement. The duration of the fast activity and the electrodecrement is going to depend on whether or not it's a tonic spasm versus a tonic seizure. As far as the EME, those are going to be focal seizures, so you're really just going to see focal discharges coming out of one specific area of the brain that move on to a focal seizure, and the myoclonus typically doesn't have an ictal representation, which is why we refer to it more as myoclonus as opposed to a myoclonic seizure. Moving on to infantile spasms, it's one of the disease processes that, at least from the pediatric epilepsy side, we get pretty familiar with because these come on a pretty regular basis, and they're usually a very acute presentation, so we can identify them pretty easily. And there's not a whole lot that we get confused with infantile spasms from an epilepsy standpoint. It's usually fairly straightforward in terms of the diagnosis. So infantile spasms were first described all the way back in 1841 by Dr. West. He wrote this heartbreaking article to The Lancet at that time where he actually described his own son having infantile spasms and having cognitive decline afterwards, kind of beseeching the medical community for anyone who was able to help him. Unfortunately, they weren't able to at the time, and it's taken us a long time to get any information on infantile spasms. It normally presents around 4 to 6 months of age, and by definition, it can be up to 2 years of age, but pretty much anyone who treats infantile spasms will tell you that we never really see it beyond 18 months of age, and if it's something that's presenting around 2 years of age, we're really thinking about something else in the differential. So West syndrome is the classic triad of hypsarrhythmia on the EEG, clinical spasms, and then psychomotor plateau and regression. And the psychomotor plateau and regression sometimes can actually precede the spasms and precede the abnormalities on the EEG. And what parents will tell you is that their child just isn't as interactive as normal. They'll say they kind of lost their spunk or lost their sparkle, and then they'll kind of stop gaining skills or maybe lose some skills that they were just learning at that time. And if it keeps going, it'll become more and more severe with actual full loss of skills. So clinical spasms are one of the, let's see if I can actually get to it, are one of the seizures in neurology that I feel like once you see them and they get ingrained in your mind, and we try and tell all of our pediatric colleagues over and over again to be sure to know what these look like so they can refer these to us as quickly as possible. Commonly with clinical spasms, what you'll see is they have kind of a brief jerk. and they tend to cluster. A lot of times they'll cry in between the clusters, and what we see is these clusters tend to happen most when kids are waking up from sleep or when they're falling asleep. Typically the clusters will only be for around 5 minutes or so at max, although I have seen 1 or 2 kids where they had clusters of infantile spasms lasting 30 to 40 minutes in length. And it's one of those really difficult situations because they don't respond to rescue medications the way that other types of seizures do. So we're not as able to kind of intervene in those sense. You just have to treat the underlying diagnosis and unfortunately ride it out a lot of the times. So this is a little kid who has infantile spasms, and it's a YouTube video that I've used for quite some time. It's a pretty good representation of spasms, and you can see he has a brief jerk of the extremities, and he has a scrunching of his face, so he has kind of a flexor component of the upper extremities. And as it keeps going, you can see that they cluster, and he actually starts to cry in between them because they're uncomfortable for him. In the pediatric world, the most common things that they get confused with is usually reflux, because people view them as arching, and then sometimes if it's new onset, people will think they're an intussusception because they think that they're having belly pain because they kind of have this crunching over and then they cry in between them, as well as the fact that with intussusception you usually think of kind of paroxysmal bouts of pain, and so it fits along with it. As far as the hypsarrhythmia goes, I think hypsarrhythmia is one of the most kind of pathognomonic EEG findings that we have, and a lot of people who've never really read EEGs can kind of even see hypsarrhythmia and identify it. It's captured interictally, so you don't need to be having a spasm when you get the EEG, and it's more commonly seen during sleep. So whenever we have a child who we're concerned about infantile spasms, we'll capture an EEG during wakefulness and sleep. And it's not uncommon that we'll actually have a child who has a normal EEG during wakefulness, then goes to sleep, and you see the hypsarrhythmia pattern emerge. Classically, hypsarrhythmia has greater than 300 microvolts in amplitude, multifocal epileptiform discharges, and is described as having a chaotic background where you kind of lose the amplitude frequency gradient that you see in kids this age. And the idea behind that is that during wakefulness or during sleep, you lose all of the normal architecture. And so you won't see a posterior dominant rhythm during wakefulness. During sleep, you won't necessarily see sleep architecture. And it's kind of representative of the fact that this pattern, this abnormal brainwave, is just kind of completely interrupting all of the normal activity of the brain. And this is one of my patients who had hypsarrhythmia, and you can see there's very high amplitude activity. This was at a sensitivity of 10. You can see some buried epileptiform discharges in here, and this one's actually during wakefulness because you can see the muscle artifact in kind of the bitemporal regions. And I apologize, I didn't include an ictal EEG, but the ictal EEG is going to look very similar to what we talked about before with the spasms, where you're going to see usually a large delta slow wave followed by fast activity and then kind of a Lecker decrement. And a lot of times you'll see pseudonormalization of the EEG where it looks normal just for a few seconds and then kind of goes back to that high voltage chaotic activity. The etiology of infantile spasms is a little challenging, and the ILE, the International League Against Epilepsy, has not made it necessarily easier with their multiple terminology changes over the years. We used to think about things in terms of kind of cryptogenic versus symptomatic, and sometimes people would throw in idiopathic. Cryptogenic would be those kids who were previously normal, developing perfectly well, had no other issues, and then all of a sudden developed infantile spasms. In our entire workup, we never found a reason why they had spasms. Kind of syndromic, or sorry, that should be symptomatic. Symptomatic is basically everything else, where you get a child who either has some type of intracranial abnormality, has a metabolic abnormality, or a genetic abnormality, and they all get lumped in kind of that symptomatic category. The new classification tries to kind of define these children by what their underlying etiology is, whether it's structural, metabolic, genetic, or this vague unknown category. And while in theory it seems like a good idea, it actually makes it extremely difficult to do research in this population because of the fact that unknown, or the cryptogenic group, is now a mess, because that actually includes all those kids, the kids who are syndromic, who don't look normal, didn't have normal development, but don't have a diagnosis, fall into this unknown category in the same way that a child who was developing normally over time and just all of a sudden had infantile spasms falls into that category. So they're thinking about it, and there may be a change in the future, but right now we've kind of moved from the old classification to the new classification, even though nobody actually loves the new one. Most commonly, these kids have structural abnormalities similar to Oda-Hara syndrome, but they can fall into these other categories as well in terms of underlying etiology. Treatment is very controversial with infantile spasms. The most common treatments that we think about are usually high-dose prednisolone, high-dose ACTH, or vigabatrin. The research in this area is awful, and the literature is incredibly confusing, where there's old studies that compared low-dose prednisolone to high-dose ACTH. There's newer studies that compare high-dose prednisolone to low-dose synthetic ACTH. There's old studies where they didn't use hypsarrhythmia as a criteria to kind of stop treatment. They just tried to get rid of the clinical spasms. So it's just really hard to compare any of these studies, and there's not any good randomized controlled trials looking at them head-to-head. Vigabatrin is used more commonly in Canada and Europe as a first-line treatment or in patients who have tuberous sclerosis. At least at this institution, we tend to think of vigabatrin usually as more of a second-line treatment behind the steroids. ACTH has lots of side effects. We know that it causes hypertension, it causes immunosuppression, as well as there's a risk for elevated blood glucoses. It's also an IM injection, so it requires an admission to the hospital to teach families how to give the medication. It's also extremely expensive. It's about $30,000 per vial, and most kids will go through usually around 3 to 4 vials during their treatment. So that's another kind of challenge with using ACTH. Prednisolone is a much better option from the standpoint that it usually has less side effects, less immunosuppression, as well as the fact that it's cheaper and you can do it as an outpatient. But the data that's out there, we suspect that ACTH might be a little bit more effective, so we tend to use ACTH as our first-line treatment in a lot of kids if we think they can tolerate the side effects. There's other treatments that we know work for infantile spasms, such as valproic acid, topiramate, zonisamide, clobazam, ketogenic diet, but those are all considered really second-line treatments behind these. And we don't know why they work, especially the steroids. We just know that they do. Prognosis is another thing that's really difficult for all the reasons I talked about before in terms of looking at the data on infantile spasms. So a study all the way back in 1993 did a really good job of breaking down the developmental outcomes of these kids. These are rated on a developmental scoring system, and it's similar somewhat to IQ in terms of the scoring, where a score of 85 is kind of normal development and cognitive functioning at that age. 70 to 85 is mild impairment, and less than 50 is severe impairment. And the black dots are the kids who have cryptogenic infantile spasms, and the white dots are the ones that are symptomatic. And you can see that of those kids who had cryptogenic infantile spasms, with the exception of 2, they all fall into the mild or normal category, versus symptomatic, probably about greater than 50% of them are in the severe cognitive outcome category. So we know if we can't find a reason why the child has infantile spasms, they're more likely to do better, which is somewhat counterintuitive to tell the family that if we can't figure out why they're having spasms, it's actually a better scenario. The other challenge that we have is lag to treatment, which also varies in all the studies that are out there. With some of them trying to get treatment within 1 month, some of them have 5 to 6 months before the kids got treatment. This study specifically looked at before 1 month and after 1 month initiating treatment, and saw that cognitive outcomes were significantly better if you initiated treatment within 1 month of onset of spasms. There's another study looking at just the trisomy 21 population that used 2 months as their criteria and showed that onset prior to 2 months they had improved cognitive and epileptic outcomes. But there hasn't been a study that's really done a nice, kind of odds ratio look at things where they really figure out what is the actual risk. Is there a time point where it really makes a difference? There's also the challenge of treatment choice, because none of the studies use the same treatment protocols, and then some of the studies don't actually look at whether or not hypsarrhythmia are resolved. So even when parents force me to try to give them a number, I usually won't. I'll just tell them that if your child if we can't figure out why they had spasms, if we got treatment early, if we're using one of the best treatments and we work to get rid of their hypsarrhythmia, the likelihood of them having a better outcome is significantly better. And I have had a couple of kids who are otherwise normal who get treated and they kind of just go back to their normal life and move on. And it's great when we have those scenarios, but it definitely feels like that's the minority.
Does insurance usually cover the ACTH?
Usually insurance won't cover the ACTH, but ACTHAR has a kind of a, I don't know what they call it, but it kind of for infantile spasms, they'll usually work with the insurance companies and with those families who have need to cover it. So usually with families, they're never out of pocket the expense of the medication, and we're able to get it for all of our families. The other challenge that we have is that it's all distributed by one pharmacy on the East Coast. So if it happens on a weekend, we can't get it, as well as the time change. So if we find about this 3 o'clock in the afternoon, we have to wait till the next day to contact the pharmacy, because they actually send it from their pharmacy to the family's doorstep. And so that has to be in place before we admit them to the hospital and actually plan on starting ACTH, do all the teaching, monitoring, and then discharging them home.
The ACTH didn't used to be expensive, right?
It didn't, and then it all got owned by one company, and then they increased the price. And they actually own the patent for the synthetic ACTH as well. They bought that, and I don't foresee them doing any clinical trials on that anytime soon. As well as they have no incentive to do any randomized control trials with the other medications, because of the fact that right now they're kind of thought of as the best medication, and so they could really only get harmed from that. So we talked a little bit about the developmental window of infancy and infantile spasms and the different etiologies that kind of go into that, and how we can see that's the same etiologies presenting as infantile spasms during that window. So I'm going to move forward and talk about childhood and about Lennox-Gastaut syndrome, which is something that you actually will see in the adult population from time to time. So Lennox-Gastaut syndrome usually presents around 3 to 5 years of age, and it's a clinical diagnosis that's a combination of multiple seizure types, an abnormal EEG, and cognitive impairment. So you'll see when we read EEGs in a child who the EEG looks like Lennox-Gastaut, we won't diagnose Lennox-Gastaut off the EEG. We'll just actually comment that this EEG is consistent with an epileptic encephalopathy such as Lennox-Gastaut, to kind of lead the clinician there and give them the opportunity to make that diagnosis, or not, if the clinical picture doesn't fit yet. So the seizures of Lennox-Gastaut are diffuse and varied. Tonic seizures are kind of the most common seizure, where you get that stiffening and the characteristic EEG change. Some people will tell you that you have to have a tonic seizure in order to have the diagnosis of Lennox-Gastaut. A lot of people will say that just 95% of people will have tonic seizures. It's not very well defined. Atypical absence seizures are very common in this population, and an atypical absence seizure clinically can look somewhat similar to an absence seizure, where you actually have behavioral arrest. Although I would say most of the time there's kind of just decreased interactiveness, but it's a challenge because a lot of these patients aren't incredibly interactive to begin with. But I've seen kids talk through atypical absence and people not necessarily be able to identify it. And it does have a very characteristic EEG pattern that's different from the typical kind of 3 Hz spike and wave of typical absence, where sometimes you can see asymmetric lead-ins from one side or the other, and then you'll see a much slower generalized spike and wave during the atypical absence, less than 2.5 Hertz, and it can be a little bit more irregular than the kind of like very nice, beautiful 3 Hertz of absence. These kids will have myoclonic and atonic seizures as well, and they're prone to status epilepticus as well as non-convulsive status. And non-convulsive status is one of those things that I think a lot of us think of it as kind of that patient in the ICU who's not waking up. You put an EEG on them, and they're non-convulsive status. This is an emergency. We have to intervene right away. And these kids, it's a little bit different. Usually what we'll see is these kids kind of have a slow decline in the minimal function that they have, and then they'll go in and get an EEG, and you'll just see that their EEG is kind of continuous epileptiform discharges, and it's not a medical emergency in the same way. And there is some data to support that kind of slower spike and wave pattern that we see with these disease processes doesn't do damage to the brain in the same way that we think about in those patients who are in the ICU having different types of seizures. So sometimes people will actually refer to this as more of a spike and wave stupor, where it's kind of someone who just has so much epileptic activity, or basically a worsening of their epileptic encephalopathy, and so we don't have to be as aggressive in treating these patients. And sometimes they don't even have to be admitted to the hospital, depending on how well they're functioning at home, and you can just try and aggressively up-titrate other medications to control it. So this is the typical EEG of someone with Lennox-Gastaut syndrome, and here you can see the classic kind of bifrontal 1 to 2 Hertz slow spike and wave pattern that at times will just kind of go on for long periods of time on the EEG, and you'll have breaks in it where you can see some slowing in the background, but this is a pretty classic finding in somebody with Lennox-Gastaut. Some people will argue that you have to have paroxysmal fast activity during sleep in order to diagnose someone with Lennox-Gastaut. Some people will say that you don't. It's once again one of those things that is not very well defined in the literature, but a lot of people who are a little bit more on the EEG side of things will be reluctant to call something Lennox-Gastaut without the paroxysmal fast activity. Etiology is very similar to infantile spasms, where it's most commonly structural. There's other metabolic, genetic, and then unknown etiologies. Structural is most common in the same way that it was with Odahara, as well as with infantile spasms. Treatment is one of the few things that we actually have some data on because of the fact that this population has been around for a while, as well as the fact that it's actually very easy to at least come up with some diagnostic criteria that hasn't changed very much over time. So there are some randomized controlled trials that have looked at felbamate, clobazam, lamotrigine, rufinamide, and topiramate, and shown that they've all been effective in Lennox-Gastaut syndrome. You can see the ends of these trials are extremely low, but the reason behind that is because these kids have so many seizures that it doesn't require, in terms of getting them below 50% seizure reduction, it's pretty easy to get pretty good power out of the study, even with small numbers. Valproic acid, there wasn't an official randomized controlled trial to show its efficacy. It's one of those drugs that had been around for such a long time that it kind of got grandfathered in and never really had that official trial that showed that it's the case. But most people who treat kids with Lennox-Gastaut will tell you that valproic acid is pretty much a first-line treatment in this population, even though it doesn't have that kind of trial to back it up. Other options that we think about in these kids are resective surgery. So if they have a dysplasia, if they have something in their brain that they know is causing problems, we'll try and go after it to improve their outcomes. Vagus nerve stimulator is an option where we can hope to get maybe about 50% reduction in seizures. Corpus callosotomy is common, especially if they're having lots of drop seizures. But you won't necessarily reduce the number of seizures, but you will reduce the morbidity associated with them. And then ketogenic diet actually has really good efficacy in this population, and given that many of these kids are tube fed, it's actually pretty easy to do in this population, so it's something that we think about sooner than we do in some others. Seizure outcomes with regard to Lennox-Gastaut. So this was a study that actually followed up people with LGS for 19 years as the mean follow-up time. And so you can see that initially they had significant burden of seizures, 97% of them having tonic seizures, and that over the years they dropped down to only about 40% of them having tonic seizures. So you can see the same for pretty much all the seizure types, and specifically with status kind of goes, and so they didn't really see anyone with status that far out down the line. So the seizures do improve over time, but they don't necessarily go away. Outcomes overall are once again fairly poor. There's about a 5% mortality associated with the disease process, and the significant morbidity that go along with somebody who has very significant global impairment. And I did it again, cryptogenic versus syndromic versus symptomatic is what I meant to put. Basically the kids who are cryptogenic actually end up having better outcomes, and they have fewer of them have severe cognitive impairment, and 72% of those who are symptomatic actually end up with more severe cognitive impairment. And the way we think about it is somebody who's symptomatic and has another reason why they have neurologic disabilities, it's kind of more of a two-hit type of idea where it's just kind of adding one thing onto another, so they just have less reserve to even manage the encephalopathy. We also see that the age of onset makes a difference, and those kids that present earlier on in life have worse outcomes than those who present a little bit later on in life. And most of the time that's usually pretty closely tied to what the underlying etiology is, but in general we think earlier usually means worse outcome in this population. So the most common lookalike for Lennox-Gastaut syndrome that I would say that we have to differentiate between is myoclonic astatic epilepsy, or DUS syndrome, or DUSA, or however you want to say it. I think we go back and forth in terms of the appropriate pronunciation because I think it's German of origin, so it may be supposed to be DOSA. We refer to this a lot of times as MAE, and it's a epilepsy syndrome where kids have normal development prior to onset of seizures, and then they develop myoclonic astatic, or atonic seizures somewhere between 7 months to 6 years of age. They have an EEG that's not particularly exciting, where they have just kind of some intermittent generalized spike and wave, but not kind of that continuous slow spike and wave that you see in Lennox-Gastaut. And the other criteria is they're not better explained by another syndrome, which really refers mostly to Lennox-Gastaut is kind of the most common one that masquerades very similarly.
What does astatic mean?
Sure. So astatic, they've actually gotten rid of the term astatic, and now they use atonic more commonly. And I'm going to show a video of a seizure that has an astatic seizure. And so some people will use it in terms of they will have usually a loss of tone or kind of a brief behavioral arrest, and then afterwards they'll have a myoclonic jerk, and so or vice versa. And so you'll see that they kind of couple these together. And on their EEG, you'll see a myoclonic jerk followed by a loss of EMG artifact in the EMG lead. So you actually see that atonic portion. And it's kind of a pathognomonic seizure for this disease process. So seizures with MAE are the myoclonic astatic, the atonic, the GTCs, and then they can have atypical absence or sometimes more typical looking absence. But I'll show you a video, and this one isn't the best, isn't the most classic myoclonic atonic or myoclonic astatic, but it's the best one I've ever found a video of. Even in the epilepsy monitoring unit, I feel like we don't see them all that often, so it's really hard to get a good video of one of these. And with this one, he actually has an atonic period followed by a myoclonic jerk. And so you can see right there, he had this brief loss of tone and then a quick myoclonic jerk afterwards. And some people will say that maybe he was just falling and the jerk was to catch himself, but you couldn't say for sure without the EEG in place. And given the fact that he's having kind of this right age range, as well as the fact that he's having an atonic seizure, I think it's pretty reasonable to think about the fact that this could be a myoclonic seizure coupled with an atonic or an astatic.
I thought you started crying before you did any of that.
He was actually crying in the earlier parts of the video as well. I skipped through those. And then these kids rarely have tonic seizures, and that's one of the most important defining characteristics between these two disease processes, is that if the child has a big tonic seizure burden, you really need to be thinking that they're more Lennox-Gastaut than they are MAE. And this can be what's so challenging about differentiating between these two, because especially in the first year where they start having seizures, you're not really sure what's the dominant seizure type and how often the seizure happening, kind of which direction they're going to go. And so it can take a year or so to really figure out which pathway these kids are headed down. And so that's why it's important to kind of have the differential in your mind and not prematurely shunt them into one pathway or the other, because the treatments are a little bit different. So the EEG is fairly bland, like I talked about, 2 to 3 hertz intermittent generalized spike and wave, and then they'll have some background slowing, and they can kind of get some semi-rhythmic theta activity in the parietal regions. And this semi-rhythmic theta activity is not specific to MAE. We see it pretty commonly in a lot of kids who have epileptic encephalopathies or have developmental issues associated with their epilepsy. The etiology is actually very different than some of the other diseases we've talked about. It's most commonly a genetic abnormality. The most common one that and by most common I still mean only about 3 to 5%, is a mutation in SLC2A1, which is actually the same gene that's responsible for GLUT1. And we see just different phenotypes associated with it. Multiple other genes or copy number variants have been associated with MAE, and those are just a list of a few of the genes, and specifically you'll notice SCN1A is in there. So that's a good example of another gene that, while we classically associated with Dravet, there are reports of these kids presenting with MAE, and kind of the difficult heterogeneity of the genetics of epileptic encephalopathies. Treatments is where it gets interesting in the fact that ketogenic diet and modified Atkins diet is actually the most efficacious for this disease process. So these are kids actually where once you kind of make the diagnosis, you will shunt these kids into the ketogenic diet or modified Atkins as quick as you can, because they're usually extremely responsive to the diets. And they don't have to stay on it forever. A lot of times they can only be on it, if they can make it for 2 or 3 years, they'll get better over time. There's other drugs that we've found that are associated with effectiveness in this population. I would say probably topiramate and felbamate are the two that have the most efficacy, working in maybe 60 to 70% of kids. But once again, there's other options and pros and cons to using all of these meds, but we really do try to do one of the high-fat diets first. Prognosis is different than the other epileptic encephalopathies, especially Lennox-Gastaut, given that about 50 to 60% of these kids end up with normal IQs, and about 50% of them end up having complete seizure remission. So there are some positive outcomes with this disease. Unfortunately, those who don't fall into this category end up with cognitive impairment and intractable epilepsy. And there's actually absolutely no way to differentiate who is going to fall into which category based on genetic abnormality, based on EEG, and there's a couple of studies that have shown that you can't even differentiate the two of them for the first year of the disease, and then during the second year they finally start to kind of parse themselves out in terms of how they're responding to medication and how severe their cognitive impairment is. So, That was a kind of a talk a little bit about some of the childhood epileptic encephalopathies, and once again kind of talking about some of the different underlying etiologies that can present in a completely different window, even though the fact that they're actually the same etiologies that we've seen in the other windows over time. And this is an overall summary of kind of everything we talked about in terms of all the different disease processes and differentiating between them. Specifically, just to kind of mention between Lennox-Gastaut syndrome, the slow spike and wave versus the generalized discharges, the different types of seizures, and then the different underlying etiologies that are common, as well as the difference in outcomes between the two. And so I think it kind of shows how you kind of get the same etiologies once again popping up during these different developmental windows with different EEGs and different seizures. And it just depends on where the child is in terms of their brain development. And that's why we tend to think about them in terms of these age-dependent epileptic encephalopathies, because it's really a lot of times all we have to hang our hat on, given the difficulty of everything else in terms of underlying etiology and definition of a lot of the syndromes. Any questions? Yes.
In the last one you mentioned the MAE. Do you think the response to the ketogenic diet has anything to do with the GLUT1 problem? I mean, I assume that's a glucose transporter of some kind.
So yes, there's not good data to support that. I think because the numbers are so small, really what you'd have. Sorry, what the question was is GLUT1. Do you think that the responsiveness to ketogenic diet and MAE is related to kind of the glucose transporter, given that they share similar genetic etiologies? And the answer is I think so. There's just not enough numbers, and there hasn't been good studies that do genetic testing on these kids to actually get a cohort of those who have that specific etiology who get put on ketogenic diet early to show that they have different outcomes than the kids who have other underlying disease processes. Because when you think about it retrospectively, you're basically doing basket trials of various etiologies and just kind of throwing the same treatment at all of them, and you're not very well able to parse out if there's one etiology that responds better than others. But I do think that's the case.
What's the main disease associated with GLUT1?
So GLUT1 is it's just glucose. GLUT1 is the kind of disease process that we usually think about, and those kids typically have severe epilepsy sometimes, and they'll get atypical absence seizures, multiple other seizure types, and then they'll also get an associated movement disorder. So sometimes they can actually present in the adult period with just movement disorder and have no epilepsy or no significant cognitive impairment associated with it. And the treatment of choice in those kids is ketogenic diet or modified Atkins. And theoretically, you can at least maybe slow deterioration versus improve. There's a lot of argument about that. And there's some clinical trials going on with other types of ketones that you're putting in the body to see if you can put other ketones that get up to the brain and help provide fuel for the brain aside from glucose or aside from being on the ketogenic diet. Yeah, thanks.